first afternoon session where we're going to talk about our breast cancer program. This is a program that is multi-campus, multi-provider, and patient specific. As we've grown this program, there's been a lot of needs, but one thing that has been constant in the backbone of our program has been our breast cancer and breast health navigators. And for those of you who have been privileged to be a part of this organization, know that Lisa Mattingly has really done a lot of work in this area, and we've expanded that now. In every MDC we've talked about today, every navigator we've talked about, we first went and said, hey, what's the history of breast cancer navigation? Because that works so well. And we owe a lot of thanks to Lisa and now, as you see, our current navigation crew. And so the breast health services vary from campus to campus. Our provider team varies from campus to campus, but one thing that does not vary is our commitment to this patient population. With that being said, our afternoon program for breast cancer is going to involve two of our wonderful speakers. Dr. Sabian is going to talk to us a little bit about surgical oncology for breast cancer. Then Dr. Cute is going to talk to us about medical oncology. Then we'll invite segments of our team to come up here and then go over a case. So with that being said, I'd like to go ahead and open the floor for Dr. Sabian to come join us. Thank you. Perfect. Thank you. Welcome. Yeah, there's a clicker up there with the green button.
Good afternoon. I appreciate the opportunity to participate in this really wonderful conference. My name's Allegra Saving. I'm one of the general surgeons that works with Norton. I'm affiliated with the Louisville General Surgery Group, and I'm primarily based out of the Norton Audubon Hospital campus. But as Dr. Spalding mentioned, we kind of cover the entire library of Norton Hospital facilities when we treat breast care. And what I thought I might, or what I was tasked with, is kind of representing the surgical oncology side of things, and thought I might just focus in on some of the updates in the management stemming from kind of the surgical management of it, although it kind of tiptoes into some of the other specialties, specifically regarding elderly patients and the early stage breast cancer. So, I apologize I wasn't here in the morning. I was operating, but I'm going to start with a group polling question, and I'll just go ahead and go through this case scenario, and then we'll kind of see how that works out with all of you putting in your answers. But this is a 74-year-old female who presented with a recently diagnosed left-sided breast cancer after it was uncovered during an abnormal screening mammogram. Both the mammogram and the ultrasound had a concurrent size of 13 millimeters, and there were no other concerning findings noted. On biopsy, the pathology was a hormone responsive or ER/PR positive HER2 negative breast cancer that was grade 2. And on exam, the mass was not palpable, and nor was there any palpable lymphadenopathy. So the question is, what would be the next step of treatment? And as you'll kind of recognize, all of the choices are surgical managements. And the reason for that is generally, particularly with our early stage breast cancer, surgery is the first step in their treatment algorithm. So the choices would be A, left breast conserving surgery, or what otherwise is called a lumpectomy, breast conserving surgery with a sentinel lymph node biopsy, breast conserving surgery with a sentinel lymph node biopsy plus adjuvant breast radiation, or a left mastectomy with sentinel lymph node biopsy. Oh, great. Oh, okay.
So that's our results.
Okay. All right. Well, good. The point of this question was not necessarily to test everybody, just kind of see where everyone's at. And actually, it's good that the results are that they are, is because that's kind of what I'd like to talk about. Is previously the choice probably would have been B with breast conserving surgery with a sentinel lymph node biopsy. Potentially, some might have said with radiation, but actually the answer, as I'll kind of point out today, is A. So really just the breast conserving surgery in this particular patient, and we can kind of omit the sentinel lymph node biopsy and the breast radiation. So that kind of moves me into what I wanted to discuss, is that what we're doing is trying to tailor the management for the surgical management, and in specifically for elderly female, and for this case, we'll say 70 and above, in early stage breast cancer, we're kind of trying to pare back a little bit in what we actually need to offer these patients to still have significant results. So the two things we'll talk about is whether or not every woman would need or benefit from having their axillary lymph nodes sampled as part of their management, and whether or not they all need to have radiation if they undergo breast conserving surgery. So in starting with the axillary sampling, in the early 1990s, kind of prior to the widespread adoption of sentinel lymph node biopsy, really we were sampling or staging the axilla with a pretty morbid operation, which is what we call a formal axillary dissection. And because of that, several studies came out, one in particular, Martelli et al., looking at whether or not that's absolutely necessary, given that it's a pretty highly morbid operation. And what they determined was that in older patients, and in this case, older than 65, if they have early breast cancer, what we consider T1 or less than a 2-centimeter tumor, that we could omit this formal axillary dissection without adversely affecting their death from breast cancer or their overall survival. And, that was kind of thought about, but kind of in that same transition, sentinel lymph node biopsy was becoming more popular. It's certainly an easier operation to perform, and it does carry a significantly improved morbidity risk in performing that. So it became more standard. And some of the thoughts of whether or not we could tailor sampling the lymph nodes kind of fell to the wayside. That was until about 2012, where an organization or an initiative called Choosing Wisely, that was spearheaded by the American Board of Internal Medicine, but kind of encompassed about 80 different medical societies and organizations to really have an open dialogue about all of the medical treatments and procedures and testing that we do, and potentially try and limit some of that if it was felt to be unnecessary. So with that, around 2016, the Society of Surgical Oncology published their Choosing Wisely guidelines, and one of them focused on the axillary dissection, specifically in the elder population, stating that perhaps we can not routinely use sentinel lymph node sampling in these older women who have favorable early stage hormone responsive breast cancers. And that was kind of initially extrapolated from those studies based off of the formal axillary dissection, and then later expanded to really focus in on the sentinel lymph node biopsy itself. And one of those studies was presented at one of the preeminent breast organization meetings, and then later was published in the Annals of Surgical Oncology, that was looking at the sentinel lymph node biopsy in this population. That was led by Dr. McKevitt. It was a prospective study of over 2,000 women, again, in this same population, all of which who had had a sentinel lymph node biopsy or underwent a sentinel lymph node biopsy. And the point was to look at the relationship between a sentinel lymph node that was positive and the adjuvant treatment they received, and then ultimately what was the survival results. So it was a 5-year study, and some of the overall survival for these women was very good, regardless of whether or not their nodes were positive. So that was the initial main take-home point, is that this particular early stage breast cancer in this population has an excellent prognosis. And then secondly, it noted that there were pretty much two risk factors that cropped up as having a significant impact on the patient's specific breast cancer specific survival, It's such that a high-grade tumor, or a grade 3, had a significantly worse breast cancer survival with a hazard ratio of about 4. And that if a patient received hormone therapy, they had a significantly improved breast cancer-specific survival. And other factors that were looked at, age, tumor size, sentinel lymph node status, or even if they received radiation, really did not significantly influence their survival. And so the ultimate kind of conclusion from this was that perhaps those patients, if they received hormone therapy, whether or not they had their axillary node positive or negative, had similar breast cancer specific survival. And so there have been many studies like that have been coming out that have continued to support those choosing wisely guidelines. And more recently, in fact, as recent as this spring, this study was presented at the American Society of Breast Surgeons that was looking again at this elderly population with hormone responsive breast cancers, but kind of looking at it in a slightly different way, and whether or not the sentinel lymph node is necessary or is the best thing to think about when we're looking at offering adjuvant treatment. So we'll say traditionally, the sentinel lymph node status, meaning whether or not a patient had a positive or negative sentinel lymph node, would be one of the main things that would guide a medical oncologist to talk about whether or not they'd offer chemotherapy. And this was kind of looking at, could we get that without having to perform an additional invasive surgery? And so what they did was they looked at oncotype scores and kind of assessed their relationship between or looked at different clinical factors that might indicate the likelihood a patient would have a high oncotype score. And I apologize for those people who are not as familiar with Oncotype DX. It's a proprietary genomic study that's done actually on the tumor itself. And it is testing for 21 specific genes. And from that, they tabulate a score that's on a 0 to 100 scale. And it's used to kind of determine how likely that breast cancer is to respond to adjuvant chemotherapy. And through testing that in the older population, and in this case, older is 50 and above, that those women with low scores or under 26 would really not have a significant chemo, but those 26 and above would. And so for this study, they use that kind of general cutoff for high and low oncotype. So this is kind of busy, but the main point is that they looked at many different risk factors here, and really only two stood out as being an significant independent risk factors for having a high oncotype score. And those were a high grade tumor. So similar to the McKevitt study, a grade 3 breast cancer. And for those that had a negative progesterone hormone status, and to a lesser degree, non-significant, but trending in that way, was kind of larger tumors. But the point of this table here is that they broke them into groups of whether or not they had a positive or negative lymph node. And the risk factors remained independent of whether that node was positive. And so the suggestion from this is that perhaps doing a sentinel lymph node biopsy wouldn't necessarily color the conversation about adjuvant treatment as much as looking at tumor-specific characteristics like the grade or the or the oncotype, which is a direct test of that tumor. And so with all of these studies coming out, this is really becoming more of a standardized, at least consideration for women in this particular age bracket with hormone receptor positive breast cancer. So much so that the NCCN guidelines, which is kind of like the general algorithms that are regarded as the standard treatment for breast cancer, has included this in that treatment arm, is that at least a consideration for omission of a sentinel lymph node biopsy should be given to women with favorable tumors and in the elderly population. So the other aspect that is we're kind of tailoring or individualizing per patient is whether or not women who undergo breast conservation surgery, which is the more common type of surgery that we perform, particularly in the elder women for breast cancer, is whether or not they always have to receive radiation therapy. And that is stemming from the kind of more traditional rules of thumb that a mastectomy or a partial mastectomy or breast conservation surgery are equivalent in their risk of local recurrence as long as the remaining breast in breast conservation is treated with radiation. That was kind of like the general rule of thumb, certainly when I was coming up in training. But as we've looked at it, perhaps that's not necessary for all women. And so there were two landmark trials that really looked at this in this age population. The first was the CALGB 9343 study that came out in 2013, and the Prime 2 study that kind of followed that a few years later. So I thought we'd look at both of those. The first study was a randomized trial looking at over 600 women. All of them were over the age of 70. All of them had hormone receptor positive breast cancer, and they all were of the T1 status, so early stage. They were clinically node negative. And they all were required to receive hormone therapy. And at the onset of this study, really the main drug that we had for that was tamoxifen. So all the women in this study did receive tamoxifen. And it was pretty long follow-up of 12 years. And what they found was that overall, the local recurrence rate, the freedom from having a local recurrence in that same breast was very good for all the women enrolled in the study. It was about 90% for those women who received tamoxifen, and it really only increased by about 8% for those women when they added in breast radiation. And breast radiation had really no impact on the development of any distant metastatic disease or the overall survival. And then interesting in this study, they did look at expected survival in both of these groups. Again, these are women with breast cancer that with treatment appropriate, whether or not there was radiation, they had an identical age-matched survival or expected survival from those patients that were age-matched, but without breast cancer in the general population. And that kind of implicates the fact that this is has a very good prognosis in this early stage breast cancer that's hormone responsive in these elderly women, which has kind of been touched on in some of the other studies I've brought up. And then the second landmark trial was the PRIME2 study that had a larger group of women that was looked at, and it kind of expanded its inclusion criteria a bit. So the women were slightly younger from 65 and above, and the tumors, they kind of extended into the T2 range of up to 3 centimeters. And again, though, they were all ER positive, and they all did receive hormone therapy. And then they were randomized, just like the CLGB study, to either radiation or no radiation following breast conservation. And it was published after 5 years with results looking at the local recurrence. And overall, again, the results were very good, regardless of the group, noting that if they were only given hormone therapy, their local recurrence risk was about 4%. And if they had the addition of radiation, it really only improved to about 1.3%. And then they further divided into women who had really strongly estrogen responsive tumors, who you'd presume would have a better response to the hormone therapy. And in fact, that did even shrink the difference a bit more. And again, there was no difference in whether or not they had distant metastatic disease, and their overall survival was identical. And then it was followed up, presented at the San Antonio Breast Cancer Symposium in 2020 with follow-up data, so 10-year follow-up after that. And it still ended up having some pretty good results, noting that the ipsilateral breast recurrence was now only about 10% for those women who just received hormone therapy, and just about 1% for those women. So overall, about a 1% per year risk difference in those women that didn't receive radiation. So from those, we've kind of extrapolated that these women do pretty well, and perhaps we don't need to treat every woman the same, and we can kind of tailor their management a bit better. And particularly for those women that are maybe in the narrow criteria, so over 70, really small cancers, very strongly ER positive, that we can really keep their management pretty streamlined. And so these are the types of conversations that we have at our multidisciplinary breast conferences. We can present the patient and kind of use some of these guidelines that have come out to really decide or individualize what would be best for each patient. And again, this is just noting that this has become a relatively standard practice nationwide, as having it be included on the algorithm in the NCCN guidelines for treatment of, or local regional treatment of, these early breast cancers. So I appreciate the opportunity to speak, and now I'll turn it over to Dr. Q.
Thank you, Dr. Staven. That was wonderful. And as you see, what a great example of how our surgeons interact with our colleagues who give adjuvant therapy. And Dr. Q is an expert on that adjuvant therapy for patients with breast cancer. And so I'd like you to welcome her to the stage so she can give her talk. And once she's done, we'll assemble our team. So thank you very much.
Right, as Dr. Spalding said, I'm Blakely Cute. I'm a medical oncologist and hematologist specializing in breast cancer. I'm going to be presenting a few different trials that were presented at recent conferences in late 2021 and 2022. But I'm going to start off with one of the abstracts was Destiny Breast 04, which presented one of the medications called trastuzumab deruxtecan, which really has made significant headway for our breast cancer population, as well as many other tumors. So trastuzumab deruxtecan is an antibody drug conjugate consisting of a humanized monoclonal protein, trastuzumab, that's linked to a topoisomerase inhibitor, deruxtecan. The trastuzumab component of TDXD acts as a homing device that helps deliver the drug to to a cell that has HER2 on it so that it can deliver its chemotherapy payload more directly on tumor cells. The antibody drug conjugate is buried inside because of the HER2 component where the chemotherapy drug is released, causing DNA damage and cell death. I'm having trouble with this, I apologize. Once it's, bear with me, guys. I'm gonna stay away from this. Once the chemotherapy is released, the TDXD portion has a cytotoxic effect, not only on the cell that it entered, but also on the cells around it, causing what we call a bystander effect, which can allow us to give much higher chemotherapeutic doses with less side effects. Trastuzumab deruxtecan approvals have been many over the past few years. The Destiny Breast 01 clinical trial was the initial study that was a two-part study. First, of course, testing correct dose, and second, evaluating efficacy and safety. There was an almost 60% response rate in a very heavily pretreated population, which is huge because most of these patients had 6 prior therapies in the HER2 positive, hormone receptor positive population. In December of 2019, TDXD received accelerated approval for adults with unresectable or metastatic HER2 positive breast cancer who had received 2 or more prior chemotherapies. The approval was based on the Destiny Breast 03, a randomized trial with HER2 positive, unresectable or metastatic breast cancer who had received prior trastuzumab and taxane therapy. Patients were randomized to either trastuzumab deruxtecan or adotrastuzumab or Kadcyla, with the median progression-free survival was not reached in the TDXD arm and was 6.8 months in the adotrastuzumab and mestane arm, with a hazard ratio impressively of 0.28. In regards to HER2 or trastuzumab deruxtecan toxicities, in one of the initial studies, 57% had adverse events of grade 3 or higher. Most common adverse events that were grade 3 or higher were cytopenias, nausea, and fatigue. But the more concerning side effects that occurred much less commonly were decrease in left ventricular ejection fraction. However, these were asymptomatic and resolved once trastuzumab deruxtecan was discontinued. And surprisingly, interstitial lung disease, which occurred in 13.6% of patients. The average time of onset for interstitial lung disease was 5.5 months. Many of these were grades 1 or 2. However, there were 4 deaths secondary to interstitial lung disease in this initial study. Naturally, when we had these results, while they were extremely exciting with such a remarkable response rate, we were worried about this interstitial lung disease, which we were not expecting. So there was big push, which we'll talk about in a second, to recognize ILD earlier. And ultimately, with the early recognition and more frequent monitoring, the severity of ILD has decreased, and there were no grade 4 or 5 drug-related ILD events in Destiny Breast 03. So key for all of our providers and anyone who has a touch point to know is the importance of the interstitial lung disease. So in the studies, patients are receiving high resolution CT scans every 6 to 8 weeks. And many of the clinicians are continuing this evaluation off study as long as we can get it approved. When we are seeing patients in the clinic who are on this medication, we're constantly asking any cough, any dyspnea, fever. We're checking their oxygenation rates to make sure there's absolutely no signs. If there's any concerning signs, the important thing is to hold. I hold trastuzumab deruxtecan, obtain a high resolution CT scan, potentially start steroids, and hold Enhertu, and refer to pulmonary, check PFTs. Grade 1 is actually asymptomatic, so just seen on screening. You know, most of these patients are getting routine imaging for their disease status anyway, so if we're finding it without any symptoms, we're still holding, potentially doing steroids and rescanning in a week or two. So Destiny Breast 04 is the abstract that was presented at ASCO in June of 2022. It's quite remarkable and very exciting for a new group of breast cancer. We used to simply have triple negative, hormone receptor positive, and HER2 positive, but now we have a group that's now called HER2 low, which is a subportion of what was previously just HER2 negative. We started looking into this because of that bystander effect of trastuzumab deruxtecan in the that we saw in our initial studies. So Destiny Breast 04 is a phase 3 trial involving patients with HER2 low metastatic breast cancer who had received 1 or 2 or more prior lines of chemotherapy. Low expression of HER2 was IHC 1+ or IHC 2+ with negative FISH. Patients were randomly assigned 2-to-1 to trastuzumab deruxtecan or physician's choice of chemotherapy, with primary endpoint being progression-free survival in hormone receptor positive patients. The study randomized 557 patients. Almost 89% had hormone receptor positive disease, and there was equal representation of IHC 1+ and 2+ patients. The majority of the patients had visceral disease and had received 3 or more lines of therapy, a time in the disease process where we typically don't see significant responses to treatment. You'll see some of the impressive results here. In the hormone receptor positive cohort, the median progression-free survival was 10.1 months in the trastuzumab deruxtecan arm and 5.4 months in the physician's choice group with a hazard ratio of 0.51. Among all patients, including the hormone receptor negative patients, median progression-free survival was still 9.9 months compared to 5.1 months in physician's choice of chemo with hazard ratio of 0.5. The hormone receptor negative patients had a good response as well in exploratory endpoints. The median progression-free survival with trastuzumab deruxtecan in that group was 8.5 months and only 2.9 months in physician's choice of chemotherapy. In the, so here we're looking at overall survival in the hormone receptor positive group, which was 23.9 months in the trastuzumab deruxtecan arm and 17.5 months in the physician's choice arm, with similar results found in the hormone receptor negative population. The clinical benefit rate was impressive at 71.2 in the hormone receptor positive group compared to 34.3% in chemotherapy. Adverse events of grade 3 or higher occurred in 52% of the patients who received trastuzumab deruxtecan and 67% of patients who received standard chemotherapy. Drug-related interstitial lung disease or pneumonitis occurred in 12% of patients who received trastuzumab deruxtecan, and less than 1% had grade 5 events. So this information, as mentioned earlier, was presented at ASCO in June of 2022. And then on June 1st, 2022, this was included in the NCCN guidelines for patients with metastatic HER2 low breast cancer. And on August 5th, the FDA approved trastuzumab deruxtecan in unresectable or metastatic HER2 low breast cancer in patients who have received prior chemotherapy in the metastatic setting or progressed within months of adjuvant chemotherapy. This is the first approved targeted therapy in patients with HER2 low breast cancer, which is really our newest subset of breast cancer in many decades. So thankfully, we have 3 clinical trials, including trastuzumab deruxtecan here at Norton Cancer Institute, that we're enrolling both in the metastatic setting and in the neoadjuvant setting. So we're able to get our patients on trial nicely here. So audience polling question. Have a 55-year-old obese female with metastatic breast cancer who presents to her primary care physician with, now, we're always available should anyone need us to call, but let's assume we're not there. Patient has new onset dry cough, mild shortness of breath with exertion. She does not have postnasal drip or allergies. She has a prior history of tobacco use, but quit 5 years ago. She does not have COPD and her PFTs were normal. Her medications include lisinopril, trastuzumab deruxtecan, and ondansetron. She's afebrile, O2 sat of 95%, lungs are clear on auscultation, and she's no murmurs in regular rhythm and rate. On a lab, showed just a mild anemia and leukopenia. The next best course of action would be A, stop lisinopril and see the patient back in 1 month. B, start an antibiotic and have patients call if no improvement. C, obtain a high resolution CT scan, consider steroids. Or C, start inhaler for COPD. Perfect. So, of course, none of these options are necessarily wrong, so perhaps a bad question, but the key here is we really just want to hold the HER2 and have close follow-up. Like I said, those ILD deaths were dramatic, and now that we're moving this drug into the neoadjuvant setting, early recognition is critical. When we first started dealing with immunotherapy, we all kind of had to educate ourselves on treatment of side effects that we associated with oncologic drugs. Because prior to immunotherapy, we didn't use steroids a bunch for side effects. So HER2 is one of those drugs that it's just kind of re-educating, getting the word out about this big concern for pneumonitis. So I'm going to move on and do one more study that was presented at earlier this year in late 2021, and it's the Emerald trial. Again, this trial is looking at additional drugs in the hormone receptor positive, HER2 negative patients, which is the majority of our patient population. As we know, we already have approved therapies, including tamoxifen, which is a competitive inhibitor of the estrogen receptor, which prevents estrogen binding. We have aromatase inhibitors, which block the aromatase enzyme, lowering the body's estrogen levels effectively. And we have fulvestrant, which is a selective estrogen receptor degrader, or SERD, which binds to and degrades the receptor, essentially removing the target. Fulvestrant is the only approved selective estrogen receptor degrader that we have right now. And it is received monthly by injection after a bolus period. Fulvestrant, while great, is only approved in the metastatic setting and does not provide the flexibility that many of our patients want. Additionally, novel hormone therapies in breast cancer could provide additional therapeutic options. And the difficult thing, though, is most of our patients over time develop estrogen resistance. And we're familiar with a mutation called an ESR1 mutation, which is most likely. This mutation suggests that although the tumor is estrogen independent, it's still likely dependent on the estrogen receptor pathway. So for these patients, drugs that bind to the estrogen receptor directly, SERDs, are likely to be effective, while those lowering the estrogen levels may not be. So the Emerald study is a randomized phase 3 trial in hormone receptor positive HER2 negative patients with metastatic breast cancer, comparing the safety and efficacy of elacestrant to standard of care hormone therapy with aromatase inhibitor and fulvestrant. Elacestrant is a novel oral selective estrogen receptor degrader, similar to fulvestrant, which is an injection. Eligible patients were postmenopausal men or women who had progressed on 1 or 2 prior lines of endocrine therapy. Patients must have had prior CDK4/6 inhibitors earlier, so either drugs that we're familiar with, ribociclib, Ibrance, palbociclib, among others. So patients were randomized 1-to-1 to elacestrant versus standard of care monotherapy. Primary endpoints were progression-free survival in all patients and in those with ESR1 mutations. There were multiple other secondary endpoints, including overall survival. Of the 477 patients that were randomized, median age was 63. Almost half had an ESR1 mutation, 70% had visceral mets, and almost 30% had had prior fulvestrant. Here are the Kaplan-Meier estimates of progression-free survival for elacestrant versus standard of care in all patients on the left, and elacestrant versus standard of care in patients with an ESR1 mutation on the right. As you can see, there is a large drop in survival initially on both lines, which is felt to be due to endocrine resistance. Once that large drop occurs, then there's clear separation of the curves, both in all patients and even more so in the ESR1 mutation patients. Progression-free survival was prolonged in all patients and in the ESR1s. The landmark analysis at 6 and 12 months showed 34.3% of progression-free survival on the elacestrant arm versus 20.4% in the standard of care arm, and an even more impressive 6-month progression-free survival of 40.8 months in the elacestrant arm with an ESR1 mutation with a hazard ratio of 0.55. The 12-month progression-free survival was impressive as well. Within a subgroup analysis, the benefit of elacestrant was maintained in almost all groups, including those with visceral mets, prior chemotherapy, and prior fulvestrant, a drug within its own class. Adverse events occurred in 92% of patients on the elacestrant arm and 86% of patients receiving standard of care. However, grade 3 and 4 toxicities were much less common, 27% in elacestrant and 20% in standard of care. There were no treatment-related deaths in either group. Typical endocrine therapy side effects were present, including hot flashes, fatigue, headaches, and arthralgias. And more common in the elacestrant group than in the standard of care group were nausea, vomiting, dyspepsia, decreased appetite, headaches, and back pain. Side effects only led to discontinuation, however, in 6.3% of the elacestrant group and 4.4% of the standard of care. So in conclusion, the EMERALD trial, elacestrant is the first oral SERD that's demonstrated significant progression-free survival for standard of care in randomized phase 3 study in patients with advanced or metastatic estrogen receptor positive, HER2 negative breast cancer in second or third line setting. There are 4 additional oral SERDs that are being studied. However, under a press release recently, the AMEERA-3 trial did not meet defined guidelines, and we will await those results at a future conference. And again, thankfully, within Norton Cancer Institute, we have oral SERD trials available for our patients, one in the adjuvant setting and one in the metastatic setting as well that are currently enrolling. And we'll move on to our tumor board. Thanks, guys.
So this time we'd like to invite the members of our breast cancer multidisciplinary team to come to the front and we will go through a case. This is again where we get to see how this collection of individuals becomes more than just that sum and give the patients all we have to offer. So thank you all for making the time to be here. Wonderful. I guess the only decision you need to make amongst yourselves is who wants to be the guardian of the clicker to advance the slides. There should be enough seats up there, Dr. Curtis. If not, would you? Perfect. The only other request we'd have, especially for the online folks, is if you haven't already spoken today, please introduce yourself and your role with the team. First time you do contribute. So thank you. I got the clicker.
Yes, we're starting out here.
Sorry, there should be a clicker that can allow you to advance to the case.
It's working.
Dr. Cornett, would you like to be the holder of the clicker? I don't mind doing it for you later. Here, let's go. All right. So it looks like we have a slide here that may allow us to discuss mammography.
Sure. Okay, well. Okay. All right, so, I have a patient, this lovely lady's about 75 years old. She has some medical history of asthma, GERD, hypertension, some chronic kidney disease, and, she's a BMI of 50. Her breast cancer, overall risk is relatively low in terms of her, risk factors, already had a hysterectomy and BSO in her 40s. She had previously had some hormone replacement therapy, but that was a little over 5 years ago. But she had stopped it. So she presented after an abnormal mammogram.
Yes, you can see on her mammogram images here that there was a 7 millimeter mass in the medial aspect of her right breast. There was no correlate. We did look with ultrasound, but we're unable to see the mass with ultrasound. So a stereotactic biopsy was performed.
The corneal biopsy, it showed invasive ductal carcinoma grade 1. ER was strongly positive. PR was positive 5% strong. HER2 immunohistochemistry was equivocal, and then HER2 FISH was negative. P67 was performed, and that was 5%, and this was in a background of low-grade DCIS.
And I guess just real quick, we had the opportunity to review some other images. And for our audience, what's this right here?
This is just showing the specimen image after the patient had a lumpectomy. I honestly wasn't sure what pictures to include for the purposes of this. It's probably overkill.
No, it's not. I mean, these are, I mean, I think the whole point of today is that the interactions that you and your awesome team have to take for granted, because you do all the time. And so for those of us that are privileged enough to work with you, it's good to understand even kind of the micro steps to go into decision making. And for example, we've already talked about three touch points for this patient with our surgeon, our mammographer, our pathologist. And I don't know, Lisa, manually, so we talked about earlier, you kind of really helped define this team over the course of your career. So is there any wisdom you can give from a patient navigation point of view that would allow us to understand kind of how that process works for the patient?
So this particular patient, we're going to get that patient referred to, we're going to get that patient referred to us after a positive biopsy. So the role then is to kind of expedite appointments, make sure that that patient gets in to see a surgeon, a medical oncologist, make sure that they know what to expect when they get to those appointments, and make sure they make their appointments. And then again, just continue to follow them through the continuum of care and always serve as a liaison between the members of the multidisciplinary team and the patient.
I think that's fantastic. And Dr. Sanders, you had given us the pathology report. I guess I would invite both Dr. Hargis and Dr. Cute to comment in terms of when you hear this pathology report, what are you thinking? We just had just a fantastic talk about the targeted therapy and new endocrine therapies. Does this pathology report play a role in what you talk to this patient about?
I think you could talk to this patient immediately with a tumor that clinically 7 millimeters and low grade and strongly ERPR positive. If in fact this is our surgical result, even with no treatment at all, the likelihood of developing metastatic disease is probably a number that's well below 1% per year for whatever her life expectancy is. So we could be, if we met her first, we'd be very optimistic and encourage her to do as minimal amount of surgery as necessary, which is the next component of our discussion.
So how does that discussion work for the patient at the surgical appointment?
This was my patient. I did meet her right after her biopsy. She's a lovely woman, but she has significant morbid obesity, very large breasts. And so I talked to her about the fact that, you know, the goal of surgery would be to probably do the least amount possible in terms of getting out the breast cancer itself. And so what you're seeing in this specimen is the lumpectomy specimen. So, and the little metallic clip that's in there is actually a radiolocalized tag. So at their initial stereotactic biopsy, Dr. Lambert will place a small little metal clip, which is meant to be identified on a mammogram. but is unable for me to locate in the operating room without some additional assistance. And previously we would use a wire that is placed the day of surgery that would go down and localize the mass, and that's what I follow to get there. But we now have transitioned, or at least at the Audubon campus, have transitioned to use these radio localized tags. So it is a similar procedure to place, although in this case, once the metal clip is in, that was placed via a stereotactic biopsy or using a mammogram, going back to place the tag, and I can let Dr. Lambert talk about this, but it's much easier and patients are appreciative that it can be done under ultrasound. Once that tag is placed, while they can't keep it forever, we don't want them to, there is not a significant timeline that it has to come out. And so it can be placed the day after I have a conversation with them, and then surgery can be scheduled at, at a later date. And we aren't necessarily dependent on scheduling specifically with the radiology department to get the wire. And it's not as, it doesn't hurt as much in my experience as having the wire placed the day of. So what we end up doing is with a little tracer, identify the tag. I explain it to patients like it's a metal detector on the beach looking for treasure. It gets more excited the closer I get to it. And then I just make sure I take a wide enough margin. And then in her case, I did talk to her ahead of time about not progressing with a sentinel lymph node biopsy. She obviously, as I had kind of alluded to earlier, is the perfect candidate, low grade, small, hormone responsive cancer. She's over the age of 70. And in her case, a sentinel lymph node biopsy, although it is much less morbidity than our formal axoid dissection, she still is at a significantly increased risk of developing complications related to that procedure simply because of her obesity. So it is very beneficial that we're able to avoid doing any of that. So anyway, that's what that picture is.
Perfect, perfect. And then I know, Dr. Cornett, you've made a career out of pioneering advanced techniques for all sorts of patients. Given this patient's obesity and comorbidities, is there anything that you and your team offer for her that influences your recommendations or counseling her on adjuvant radiation?
Right. So, this final pathology, if this is the small estrogen receptor positive, she sort of fits the CALGB study that Dr. Saving outlined, that first study, over age 70, small receptor positive, and probably a real good candidate to do endocrine therapy if she's someone who's committed to the endocrine therapy, includes surveillance. Of course, that all depends on that final pathology evaluation. Other things like just the techniques, just having a patient with a larger breast or sort of larger body habitus sort of increases the risk of some of the acute and late effects of radiation, such as skin reaction, fibrosis, or breast edema. So when I'm looking at this up front, I'm hoping that she's someone that can avoid radiation, and that's good for her. And but if I saw her before her surgery, we see some of these women, they think they're going to have the breast removed and avoid me, or they're going to keep their breast and have to put up with radiation. And it's kind of nice to tell them that they may be able to keep their breast and avoid me. So that's sort of what I'm thinking. If it does come to a situation where she needs treatment, we do have techniques to assist with that. We do have cone positioning that just technically allows the breast to sort of separate from the torso a little bit to help with angles and limit some of the sort of acute radiation reaction by helping us distribute that dose evenly with less risk to normal surrounding tissue.
And another thing too, that sort of tied into some of the research that's been done at Norton Cancer Institute, is the impact of physical therapy on these patients. And I don't know, Audrey, if you'd like to comment a little bit on, for this patient, even it sounds like with our excellent care, her breast cancer risk of affecting her later is going to be low, but what type of physical therapy opportunities do you have with this patient given her intersection with the team?
Yeah, no, absolutely. So this is somebody for sure that would benefit, given her comorbidities of obesity and some of her cardiac comorbidities. some of those side effects that Dr. Cute mentioned, adverse events for AIs, the arthralgias, myalgias, and sometimes even potentially cardiac events that can happen, as well as down the road, even pelvic floor sexual dysfunction type needs. So this is a perfect patient that we can get set up with a physical activity exercise program to promote bone health, as well as any weight gain that may appreciate further with this patient, as well as manage those bone and joint aches. So this is where we would definitely get involved with this type of patient.
Perfect. And one may suppose that for a patient with a smaller breast cancer, not under 40, are there any sort of genetic issues that this patient would fall into?
No, so for this patient, she didn't end up meeting with genetics. She has a couple low risk things going for her. She's over the age of 70. She had no reported family history, so genetics just wasn't a factor in her care.
So maybe what we could do is shift gears a little bit. It looks like we have some imaging here for a second case.
All right, so I have a second case. This is JK. She is a 52-year-old female with a history of bipolar disorder, alcohol and cigarette use, no family history of breast cancer. She presented with a left palpable mass. Her prior imaging before this was before COVID. So could
Next
So-
slide.
Yeah,
even
well,
go,
sorry.
go back.
Yeah, on the
Okay.
mammogram pictures, you can see there's a little triangle marker, and we use that to indicate that this is an area that the patient is feeling. She does have heterogeneously dense breast tissue, but there is an obscured mass in the region of the palpable marker, which is better seen with ultrasound, which I think is on the next slide. So the mass under ultrasound measured 37 millimeters. Those are the two left-hand pictures. And then because of this, the mass was large, or, greater than 2 centimeters, we did take a look in the axilla, and she had a lymph node in her axilla that showed some cortical thickening there of 5 millimeters, which is abnormal. We allow lymph node cortex to measure up to 3 millimeters. So this was technically enlarged. So we did biopsy the mass and the lymph node with ultrasound guidance.
Yeah, so the corneal biopsy of the breast mass showed invasive ductal carcinoma grade 3. Estrogen receptor was low positive, 10% weak. PR was negative. HER2 was equivocal by immunohistochemistry, and HER2 FISH was positive. T67 was 80%. The corneal biopsy of the lymph node showed metastatic carcinoma, and the receptor studies were the same as the breast.
So she has a HER2 positive breast cancer. In that situation, we, in tumors that are greater than 2 centimeters or lymph node positive, we do neoadjuvant chemotherapy. But she was evaluated by surgery up front, as well as radiation, medical oncology, genetics, all within our multidisciplinary tumor clinic.
And so Dr. Q, you mentioned this patient got neoadjuvant chemotherapy. There's been decades of research looking at what we call preoperative or neoadjuvant versus postoperative or adjuvant therapy. When you're having that discussion with the patient, what are some of the benefits that she may experience from neoadjuvant chemotherapy?
So particularly in our HER2 positive and our triple negative breast cancer patients, we tell them that, so there's a theoretical benefit of potentially decreasing or killing off any cell that may have already spread that we can't see. There's also the benefit in knowing how the tumor responds and then how we can adjust for therapy later. So particularly for HER2 positive disease, if we know that if we treat it up front, we go to surgery and there's residual disease, we can alter our adjuvant or therapy afterwards and have improved benefit. So it helps us adjust our treatment, which resultantly helps us improve overall survival in these patients. On the flip side, I tell them we're getting the hardest part over with first. Sometimes some people they go strong, they're fine for it. Other people are very nervous if they have a tumor in place. We don't re-image throughout neoadjuvant therapy unless we have concerns that it's growing, but we do exams regularly. And we typically with HER2 positive breast cancer patients see a nice clinical response throughout therapy. Thankfully for this patient, though, we were able to include her. Do we have research here? No, so we were able, our research team reached out and she qualified for one of our clinical studies. And so she opted to consent to a Destiny Breast 11 clinical trial, which Dr. Agarwal is PI on, which is testing neoadjuvant in HER2 or trastuzumab deruxtecan.
And so we had talked a little bit about in the beginning with lymph node positive disease management of the axilla. I guess I would invite comments from Dr. Saving and Dr. Cornett in terms of someone getting neoadjuvant chemotherapy. How does that influence surgical decisions as well as potential radiation targets and expected comorbidities as a consequence of that discussion?
Well, in terms of surgery, one of the additional things that we kind of nudge patients towards neoadjuvant, in addition to the benefits that Dr. Hugh just mentioned, is that this is a pretty large tumor, and depending on the patient's breast size as it relates to the size of the tumor, you know, the option of having breast conservation is the first thing to think about. Is it's very large and the breast is small, it's going to be really challenging in order to get a good cosmetic result with that. And if they aren't interested in breast conservation, it still would benefit, because if the location of the tumor is, say, closer to the nipple or closer to the chest wall, things like that, even if we were going to perform a mastectomy, perhaps shrinking the tumor some would allow for an easier attempt at that too. So from just how we deal with the breast surgically, shrinking the tumor or potentially to the point of not being able to see it anymore, you know, it is always helpful in terms of giving a broader availability of surgical options to the patient.
Another thing we didn't mention that Dr. Savings can comment on is sometimes we can basically, we call it sterilize the axilla. So we can potentially turn the axillary lymph nodes negative, may be able to avoid a sentinel, an axillary dissection.
Yeah, and I'll let Dr. Cornett tag team this, because it does kind of factor into what we can do. So traditionally, if a patient had a positive sentinel lymph node, we would need to clear the axilla by operating and removing all of the lymph nodes in the armpit, which is terribly morbid, but I kind of alluded to why we were trying to get away from doing that for everyone. And knowing upfront she's a positive lymph node, it previously would have had us consider talking to her upfront about it at some point having to do that. What's nice is that if we biopsy it and Dr. Lambert can place a little clip in that node, after neoadjuvant, if everything seems like it is, we're gonna do some type of surgery on the breast, however that patient has chosen to move forward with, and then go and do a sentinel lymph node biopsy. And at the same time, if the sentinel lymph node is not the clip node, also go and acquire the clip with having a tag placed, so that when those are analyzed in the final pathology, if the neoadjuvant chemo has eradicated, there's no evidence of any cancer left in those nodes, then we wouldn't need to do any further surgery on that axilla, and may or may not choose to, or what Dr. Burnett can offer.
Right. So medical oncologists do a real good job in these cases, especially for HER2 positive disease. And right now, if we have someone with a positive node like this, and they go and have the axilla sampled, right now the standard of care, just because that was positive beginning, we would do regional nodal radiation. And we know those patients do better, but we don't know if they do well enough that we can omit the radiation in that situation. And we actually participated in an NSABP B51 trial trying to answer that question. And that study is close to approval, where they randomized between treating the axilla or observing if the axilla is cleared with the chemotherapy and no disease at the time of surgery. But we don't have the results of that study yet. And outside of that study, we would treat the axilla.
Well, that was great. I think maybe the audience would benefit from what surgery did this patient have, and then kind of what was her postoperative rehab course like.
So we're looking forward to that too. She's in the middle of her.
I think I'll just add an additional point. The neoadjuvant therapy we had even before our very exciting clinical trial we have a pathologic complete response rate in a patient like this, even with a tumor that's relatively large and positive lymph nodes, of typically 60 to 70 to even 80%, meaning no tumor found at time of surgery. It was very exciting for the patient when we tell them about the neoadjuvant. You can give the treatment today on Friday with our HER2 targeted treatment for neoadjuvant. And they'll notice on Sunday afternoon, the breast tumor is considerably small. Suddenly they're all in on the neoadjuvant.
Yeah.
But it's very exciting. And we're hopefully even improve that with the HER2 exciting drug that we already talked about.
So just as Dr. Hargis was saying before we go to talk about rehab, with this patient, with one cycle of trastuzumab deruxtecan, her tumor is no longer possible. So pretty remarkable response right away.
So I guess for the sake of completeness, this drug's gonna work great. Nothing's gonna be left. We're just gonna have a clip and we have to remove the clip. And let's say she has a clear axilla, so she gets the node removed, she has a lumpectomy. What would her kind of post-operative physical therapy look like?
Yeah, so, well, a couple things. She definitely would have post-op rehab, but actually we can be doing rehab during neoadjuvant chemotherapy too. And so a lot of times we will do rehab during neoadjuvant chemotherapy to optimize performance status prior to surgery, to make sure that they optimize their function during chemotherapy, especially if any of the chemotherapy agents are cardiotoxic, neurotoxic, things of that nature. So depending on that patient's performance status, we may even involve it neoadjuvantly. Post-op, definitely if the patient ends up having either lumpectomy or mastectomy, we can address any upper quarter dysfunction that comes from that, whether it be joint range of motion, stiffness, pain, anything that comes from that. And then obviously to address any concerns of lymphedema risk reduction. So with this patient, you know, obviously she probably is going to get regional nodal radiation at some point, if she's going to have node sampling, we are going to advise her in lymphedema risk reduction strategies and exercise and activity to address that.
And then I don't know for this patient, is there genetic risk or something that you would comment on? And if not, who would be a patient that would someone that would definitely be more involved with genetics?
Yeah, so this patient actually did meet NCCN criteria for genetic testing. I want to say it was a father with pancreatic cancer. So she didn't meet with genetics. We ended up ordering a larger panel. So not just the breast cancer genes, but also things like ovarian, colon, uterine, pancreatic. Really a pretty broad test that can give us a lot of information. She ended up coming back negative. No cancer causing mutations were found. So some peace of mind for her family. And that can also guide with treatment decisions. If there's not an increased risk for a second breast cancer, we can typically lean a little bit more conservative when it comes to surgery.
So I think I just want to join with the audience, give you a round of applause. It's amazing what you all do. And as you can see, the breast cancer care is so complex, and I'm just so happy that we have these wonderful providers up here, as well as our other colleagues to help take care of that. So thank you very much.